Good morning, everyone. Thanks for coming to Grand Rounds today. Today, we're fortunate to have Dr. Deb Marin spend time with us, and I'll turn it over to Ali to introduce Deb.
Good morning, everyone. Thank you again for joining us on today's virtual Grand Rounds. Again, this morning, we're very excited to be hearing from Dr. Deborah Marin. Dr. Marin earned her medical degree and completed her residency in clinical psychiatry here at Mount Sinai, followed by a research fellowship training at Cornell. Since rejoining Mount Sinai in 1992, she has held a wide range of leadership positions, both within the Department of Psychiatry as Chief of Geriatric Psychiatry, Director of the Geriatric Psychiatry Fellowship Program, Vice Chair for Education and Medical Director, and within the broader institution as Executive Vice President for Strategic Development, Chief Medical Officer, and Director of the Center of Spirituality and Health. She is the George and Marion Blumenthal Professor of Psychiatry, as well as an Associate Professor of Geriatrics, and is additionally the inaugural director of the Center for Stress, Resilience, and Personal Growth. Beyond her administrative work, Dr. Marin has led NIH-funded studies investigating aging and dementia, and is a widely recognized expert in the treatment of memory disorders and depression, as well as a deeply valued teacher of medical trainees of all levels. A very warm welcome to Dr. Deborah Marin.
Thank you so much. Thanks, Ali. And David, thank you. And I'm going to share my screen right now. Okay. Can you all see it? Good. Okay. So I'm going to be giving a talk today about the behavioral health consequences of trauma related, obviously, to COVID-19, and to talk a little bit about our center and what we are offering. So I do not have any conflicts of interest. So I'm just going to review quickly the highlighted items of what are stress-related conditions. And as you as internists, I know you're quite familiar with depression, but for those to remember, people who experience at least 2 weeks straight of being down and depressed, not enjoying things, one item. The other item, though, is people don't have to feel depressed, they just don't enjoy doing things. And then there are associated features you're familiar with too, I'm sure. The next, of course, is anxiety disorders. And the anxiety is so prevalent here and so much of the time that even if someone does not meet criteria for an anxiety disorder, the feeling of being nervous and anxious or on edge all the time has a lot of implications, particularly actually for sleep and concentration. And of course, PTSD. And this trauma, what we're experiencing here is different from a lot of traumas that have been studied, but nonetheless, the symptoms to think about is intrusive thoughts. You can't stop thinking about it. You avoid doing things. You have inability to see positively things that are occurring, and hyperarousal, which can be evidenced by startle response and irritability. What's interesting is the neurobiology of all these illnesses actually is quite common, and there's prevention is obviously very important for these, and strengthening protective factors. And the issue here of social support will be a theme you're going to see throughout actually this presentation. We are social human beings. And of course, try to reduce factors that can contribute to it, including substance use, which, as you know, is on the rise, as well as in our discipline. And the treatment for these disorders, while pharmacotherapy is like the go-to treatment, particularly in primary care, it turns out that psychotherapy, particularly cognitive behavioral therapy, interpersonal therapy, mindfulness, and trauma-focused therapy work extremely well. So what are the workplace manifestations? The issues about behavioral health disturbances is that they alter behavior. So what's been found for PTSD and depression is that it's associated with absenteeism and presenteeism. Presenteeism is you're there, but you kind of check out. You check in, but you're really not there at work. Clearly can have an effect on patient care. Irritability, anger, loss of joy, happiness in one's work, not being motivated to do things, sounds like burnout, obviously, fatigue, and breakdown in unit cohesion, which is particularly challenging given the fact that we do know that there's been a lot of that going on. And of course, secondary stressors for those who have children, childcare issues, financial impact. For every 1 point decrease in GDP, there's an increase in suicide in the nation, and of course, unemployment. So moral injury, this comes from obviously vets, who fought wars, but I think this is relevant to the work that you guys in general have been doing. So difficulties in functioning that sometimes emerge following exposure to potentially moral injurious events. And they relate to actions or one inactions. And examples I can think of for, medicine is taking a patient off potentially life-saving treatment to make it available to someone else, failing to properly screen a patient, resulting in another vulnerable patient being exposed to COVID. We know that's occurring. Working in a healthcare system that rations resources. I don't think that's true for this system, but it's definitely true, as you know, universally. And of course, the problem is that then these moral emotions and cognitions are avoided or suppressed, resulting in the likelihood of more suffering and the development of actually PTSD. So this slide is used often for folks who study trauma. So the y-axis is what is one's reaction when the event occurs, and what happens over a 2-year period. So if someone has a mild reaction, look at the bottom stipple graph, they feel grateful, they feel okay, they're doing well, the likelihood of their developing a problem later on is very low. However, those of us who experience some sense of being affected negatively, but still functioning, things could go 2 ways. One can go and do well and recover, but there's also the chance of late onset PTSD. And that has definitely been seen in our World Trade Center program here that started in 2002. And of course, for those who are really disabled, they really are thrown into just not being able to focus, concentrate, dazed, cannot see that they actually were able to survive the event. Those folks are quite likely actually to develop a PTSD.
Sorry, I'm still not sure about.
Sorry about that, and other associated illnesses. So you may have seen this slide. This really, I think, is very representative. This is a slide that has to do with trauma in general, and we can use it, I think, for us here at Mount Sinai. Here, the idea is that, again, the same idea, the y-axis, how are you doing, emotional high or low? You're doing okay pre-disaster. A threat occurs, March 11th. Then, as we all know, all hands on deck. People are heroic. They work extra hours, extra shifts. They agree to be redeployed. Then what happens is, as time goes on, we become disillusioned. And one can say that maybe in the summer, we were doing a little better. Then we started again with another surge, not even anniversary, just another surge, and we're back at being disillusioned. And the issue here is that I think no matter who you speak to, I don't think anybody's going to say, I feel terrific, I'm great. This had a positive effect only on me. And that's the issue right now with COVID-19. So what leads to folks having behavioral health issues related after a trauma? One is dose of trauma. The closer you are to it, the more likely you are to be negatively impacted. Previous exposure to trauma may inoculate you, but also may make you more likely to have a recurrence of your symptoms, prior psychiatric history. Of course, low socioeconomic status, folks who have been, affected by racism, disasters, other things. There tends to be a lack of what's called community resilience, resources for them. Again, lack of social support, secondary stresses we talked about, female gender, and actually BIPOC folks, because usually that has to do with, unfortunately, a socioeconomic status. So this study you may be familiar with is MMWR, published in June, and it showed that in a large study in the United States, 40% of folks said that they had one behavioral health condition. Anxiety, 30%, stress-related reactions, 26%, substance use, 13.3%, and serious considered suicide, 30 days. You can use this slide for many studies. What's been shown is a third of folks who had COVID-19 have behavioral health consequences. I think it's very important, obviously, for the folks you treat. And in addition to these, there are cognitive issues as well that are going on. I'm sure you're familiar with that as well, probably due to neuroinflammation. And in a national study of physicians, what was found that 2.6% had suicidal ideation in the context of COVID. So this is from the same study, looking at, so what if you're a frontline worker, not just the healthcare workers? And as you can see, this is the odds ratio. 2.0 for anxiety disorder, over 2 for depression. Of course, I think what's important here is substance use. 3.5 odds ratio. And again, suicidality. And folks who are between 18 and 24, individuals who were not white, were much more likely also to have these symptoms. I'm not going to talk much about John Ripp's work. He and I we work very closely with OWBR with John and Lauren and their wellness champions. I'm not going to focus on this. I know John is going to be talking with you, but just to review, in the study they did, if you look at the upper right-hand quadrant of over 2,000 folks back in March, found that 26% screened in for major depression, 25 for GAD, and 23 for PTSD. What I will show you, and he's going to show you many more slides, is so what mitigated these factors? And this fellow, Rob Peterzak, the first author here, we collaborate closely with, and he's really very well known for work in trauma at Yale. And he looked at, so what are the factors that actually prevented folks from developing these behavioral health consequences? This is Mount Sinai data. Folks who seemed interested, they had self-efficacy, they were enthusiastic, no substance use, purpose in life, and support. And I bring this, and gratitude. I bring this up because these map onto resilience factors I'll be talking about. So we talk a lot about the negative consequences, but in addition to that, people can experience positive consequences. The term post-traumatic growth really, just like resilience, only became something to think about in the 90s. Usually, we as physicians think about pathology, but starting in the 90s, people thought about resilience and PTG. And post-traumatic growth is not generated by the trauma, but rather by the victim struggling with the trauma. And the domains include improved personal strength, increased relating to others, spiritual and existential changes, greater appreciation of life, and identifying new possibilities in one's life. A lot of work has been done, particularly actually with veterans. Folks have been through Sandy, hurricanes, tsunamis. Before I go on to the slide, the one thing to think about is what is the relationship between how can you have post-traumatic stress disorder and have post-traumatic growth? This study just came out this week, again by Rob Peterzak, and they've been following over many years thousands of veterans. This most recent study is almost 8,000 veterans participated in 2019 to 20 in the National Health and Resilience in Veterans study. As you know, there's a lot of concern about suicidality in veterans. So a lot of work is looking at how to shore up their resilience. So about 3,000 veterans completed a survey that assessed PTSD, suicidal ideation, and post-traumatic growth over 1 year. And what they found was that 43% indicated they experienced moderate or greater levels of COVID-19 associated with post-traumatic growth. And what were the variables of these domains? Appreciation of life, relating to others, personal strength. What's interesting, as the veterans who actually had PTSD, they said that 71% of them endorsed post-traumatic growth. Well, how can that be? So there are three relationships that have been found in the literature. There's a direct relationship, positive correlation, there's an inverse correlation, and there's a U-curve correlation of PTSD and PTG. This study happened to show a positive correlation. And people can suffer and have experience at the same time grow from the experience. And that's the take-home message from this. So now I'd like to move on to resilience. I mean, post-traumatic growth is different from resilience, but their domains are quite similar. And the question is, so what is post-traumatic growth is a journey, and as is resilience. Resilience, I highlight here, there are many different definitions. The reason I'm showing different definitions is that in part has led to some difficulty in understanding the literature because different people have different terms to use, different methods to assess. So one is the ability to adapt. The other is the ability to bounce back. The next is these things accumulate over time, and it can be a journey that has its ups and downs throughout. And it is active and dynamic. This is not an on-off switch. And very recently, a very good conceptualization of resilience came out in the Lancet. And this is saying, so what contributes or what detracts from it? There's definitely some genetic and epigenetic component to the biology of resilience. In addition, however, there are issues about what kind of system are you in? Are you in a system that is supportive of you? Did you grow up in an environment that helped shore you up? Was there social support in your environment? And actually, what's been shown is that some level of stress in childhood actually is good. If somebody's completely protected from potential traumatic events, that may make them less able to cope later on in life. Then, of course, there's the environment. What's your neighborhood like? Is there a food desert there? Are there parks to go to? What's the natural environment? What's going on in the climate? And all these things go, all the positive versus negative, contribute to the overall ability for one to be, or for community to be, resilient. So Dean Charney and Steve Southwick, and Steve Southwick works with Rob Peterzak at Yale, and Steve now is also at Mount Sinai, wrote this very nice book, and they basically put together what have been viewed as all researchers by what are the factors that contribute to resilience. And these are actually, they're somewhat correlated, but they're also independent of one another. One is optimism, to try to see what came out of it that may be good. Being able to face fears, being avoidant of fearful situations, which is kind of what PTSD is like, actually makes one, the avoidance causes more biological problems to more avoidance and more anxiety. Living by one's own moral compass, this is where moral injury comes into the situation. Faith and spirituality, spirituality is not the same as religion. There are similarities, but having some connection to some higher power or force or community helps folks. Social support again, resilient role models, taking care of oneself, which, as we know, as physicians and healthcare providers, we're not necessarily so good at that. Brain fitness, I think we're pretty good at that. And being able to with flexibility, look at the trauma and try to figure out how to move on. And of course, finding meaning and purpose. And there's some similarities, as you can tell, with burnout too, which I'm sure John Rip will talk about. So what are the studies? As I mentioned before, resilience is measured in different ways. These are studies that I chose for residents and attendings, and they looked at, how can they improve resilience? And what was found was that actually it's pretty intensive intervention you have to do. MASH et al., basically 2 studies, did 12 weekly 2-hour sessions of CBT and problem solving versus waitlist. And indeed, they did find that both residents and attendings were more resilient. I do want you to note that these methods of improving resilience are not necessarily proven techniques to improve resilience, but they're very reasonable because problem solving is important. Bird's study actually just had 4 sessions over 2 years with medicine residents, and that did not work out so well. Decreased resilience, increased burnout, probably because the intervention was not focused enough on maybe what needed to be done, mindfulness or CBT. And again, another study by Schroeder, again, pretty intensive, 13-hour modified mindfulness-based training with follow-up sessions versus waitlist. And indeed, again, these folks did have decreased burnout. No change in resilience, no change in personal achievement, and no change in quality of life. I don't think you should take these studies as meaning anything other than these are attempts. They're small n's, you can tell. They're not randomized controlled trials. And they measure different things in different folks. It's very hard to compare these studies. But there's a literature that's coming out there. So now I'm just going to turn a little bit onto the center. So we opened our doors actually in June of 2020. And the mission was to be a centralized resource to provide resilience training. We developed an app, which I'll talk about a little bit, and to provide treatment and outreach. The center was started on the premise that the work that was done with first responders to 9/11 would be adaptable to this. And because there's so much work done on resilience and trauma here in the Icahn School of Medicine, it was kind of like all hands on deck, if you will, in March. And John Rip started a task force, which I and the departments were part of, expecting to really have to take care of folks. And as you know, there's 24/7 hotline. There were ability, people were walking around the floors. There was ability to sign up for groups. And what was interesting was there clearly was an uptick in people going for behavioral health care. Folks did not call the hotline very much. They did not attend the groups very much. If anything, the folks who were used really a lot were the chaplains because they were rounding on the floors. And I don't have data to share with you here, but I can tell you that the chaplains did a tremendous amount of staff care during that time. And it's never returned quite back down to the way it was pre-pandemic. So that's how the center all started. And then with the data that RIP had was like, well, gee, you know, look at this. We have all these stress-related conditions. The work that's we're doing a lot with EAP, HR, and OWBR and psychiatry is, you know, how do people find where to go? And that's one of the biggest challenges, as you know, and John Rip's group, again, with Lauren Pecorello's done a great work on this. And basically, we're a small group. However, we are available a lot, and we do want to be a resource for folks. Even if you don't come to be treated or have a workshop with us, we can steer you in the right direction. Resilience training we'll talk about more. And our outreach, this actually is based upon Carol Horowitz's work on community-based participatory research. We have an accelerator as what she would use. We have stakeholders from hospitals in the system, and we meet monthly. And actually, what they told us had a lot of effect on what we landed up doing with outreach. So what we found was we had 11 workshops. Over 70 folks were trained as peer leaders, a lot of excitement in July, and then they did not come. Because there were a lot of workshops, there were 60 minutes in duration, even though HR said you can take time off to do these things. How can you do that? You know, with a nursing shortage, with folks being ill. So we decided to collapse them to the factors related to the literature you just saw. We now have 5 workshops. One is engaged in optimism, active coping and facing fear, taking care of oneself, social support, which means seeking it as well as giving it, and finding what gives you meaning, and spirituality with faith. Well, we've also learned that we really have to go to where people want them to be, how they want the workshops to be. They are educational sessions of small groups in which each session starts with describing the factors we're talking about, then asking the group actually to talk about their experience with this. It's not group psychotherapy, but it is a place for people to share in a group setting. That's one reason why the previous literature on the groups works so well with residents and attendings. There is something about the group dynamic. And then people can choose from a menu of what's called a resilience plan. Something that's actionable, doable, and then you try to do it 15 minutes a day, 5 days a week. And we also have the ability to document it through our app. We've done over 90 workshops throughout the system. It's actually gaining quite a lot of steam actually with trainees. I'll talk about that more. So this is our app. The app was started because given the high frequency of behavioral health consequences, it was decided very quickly that there should be a confidential method for employees. This app is only for employees, students, trainees, and staff, faculty of Mount Sinai Health System on do a self-check-in. And you can download it from Sinai Central. You have your own code to get in. We do not know who's using it. We do see data from it, but we do not know at all who's using it. And over 300 folks have downloaded it. This is the V2, by the way. We're now on V3. And the way it works is you sign in, you click on how you're doing, how I've been, my resources, and then you have logs. You can log in, you know, how you're feeling. It has to do with depression, anxiety, post-traumatic symptoms, well-being as well. We use the audit for alcohol use. We give available resources, and we also let folks go to see the chaplains or reach out to the chaplains. This is, again, this is V2. V3 is much more dynamic. One clicks in how one is doing. Immediately they get a score. It's green, means that they scored less than 9. This is the PHQ-8. There's no suicidality question in the PHQ-8 for depression. If it's 10 or higher, you get a yellow, and then you have a calendar and you can see how you're doing. So you can see your course. Whoops, sorry. I'm sorry. One other thing I don't have here is that we also have the ability to journal. Journaling has been found to be very helpful. I can tell you right now, this has been built closely with Hazel-Platter Institute for Digital Health. And right now they're working, I'm saying we, the royal we, I am more listening to the amazing stuff that they're doing, actually to build an app that actually promotes resilience. And that's going to be a randomized controlled trial, by the way. So our outreach efforts, a learning actually from what the chaplains did, because I run that other chaplains, you know, the Center for Spirituality and Health. we learned that you got to get out there. We do have a very confidential offices for folks to go virtually to talk. People can come down in person if they want. We have trained social workers in treatments for PTSD, depression, and general anxiety disorder. And we round. So Steffi Rocha is at Mount Sinai, Queens. Maha Akhtar is at Mount Sinai West. And then we have Adeline at Mount Sinai Morningside. We are going to have a social worker here at MSH as well. The thing is that it turns out that the majority of folks who are using actually our center are ready for Mount Sinai Hospital. I think that's partly because we are here and there are a lot of resources at this particular site. But going out, what we found with the social workers going out, these are our social workers in the center, is that we get referrals and we get requests for workshops. There's a lot of stigma, as you well know. And we do work very closely with the warmth teams. These are the psychiatry attendings and other staff members who actually round on the floors of the different hospitals. And the chairs of psychiatry are doing this. Very senior folks are doing it. And we're working closely, as I mentioned, with OWBR. And what we learned is you got to get something out there. You can't just, we have flyers in Spanish and in English for on screensavers. Nobody looks at screensavers. So we decided to buy 10,000, actually 2,500 first round chocolate bars, which you may have seen. We have them around the hospital, and we also now have coffee sleeves. You can use a QR code to get in to see us. We're trying every way we can, particularly to get to individuals who don't readily have access actually to screens or computers. We're thinking, of course, of the folks who serve food, transport, very important to try to hit that group. And I think we've done fairly well in that, again, John Ritt's most recent study, 40% of folks in at Mount Sinai know about us, even though there are literally 5 social workers. John Shapiro is the clinical director, psychologist, Craig Katz, Von Sharma, and me, and a half-time psychiatrist. And that we're small, but we are available. We have a social worker available at this time still 7 days a week, 9 a.m. to 9 p.m. phone coverage. And we probably will be tailoring back on that a little bit because we've had maybe 6 phone calls over the past year on the weekends. So, but we have put a lot of effort to making sure we're available. Our treatment hours are also pretty flexible, including can be on the weekends if necessary. We spend a lot of time working with finance and what's called the central billing office to actually make deals with UMR, which most of you are covered by, 1199, Oxford, which is for NISNA. There are 13 unions, by the way, at Mount Sinai. And we've cut a deal that they agreed that there'll be no cost sharing. As you well know, there's no cost sharing. Anyway, maybe don't know, but there's no cost sharing, sort of for behavioral health right now. We really wanted to make sure, even at a high deductible, we wanted folks to be able to come to care for us. And we offer up to 14 visits at no charge. And then we have handoffs to psychiatry or the behavioral health clinic or FPA, or we have to send this handoff to the other insurance companies. But it's highly unusual to have something like this. In fact, certainly in the New York area, nobody has this. And on a national scale, from as I've been in, I haven't heard this happen either. So it's a very wonderful opportunity. What we've learned is that actually almost 20% of folks who come into our clinical practice are actually 1199. Now, for those who don't know, psychiatry FPA is a real lockdown practice. Even my chart, you don't see information for, let's say, if Jane is a patient of mine, for example, and she writes me a note, she needs a refill. No diagnose, unless the psychiatrist goes to the problem list that's shared with other folks in the institution, nobody would know that there's a psychiatric illness. The only things that are shared are medications for obvious patient safety reasons. So we try very hard to let people know that we know people don't like to come for care. We know there are issues about credentialing, which we're working with the credentialing office as well about the issue of behavioral health care. But we're trying everything we possibly can do to make ourselves accessible. So far, 75 employees are now currently in our care. Over 100 have been in our care, and we have become pretty busy. This is our stats. We started on October 3rd. We opened our doors, and you can see a, substantial increase from October to December, and we're still growing a lot. We had 220 visits. We have a 1% no show rate. We do a lot of work to accommodate folks who want to see us. The way people get into this is they call and they get a screen, again, a confidential screen. It goes into RedCap, but nobody would know who's in there. And then they're given a treater, it was a social worker with med management as necessary. The majority of folks are not getting med management. So let's talk about the workshops now. I just point your attention. So the start of picking the workshop titles was from the book on resilience. As I mentioned, we honed it down to 5 workshops. Actually, now over 90 workshops have been done with more than 100 employees. And so who's been using us? The clinical nurse managers as MSH and MSW. It turns out that MICU, 10 East, several units, 3 units on 10 East. The workshops are run actually by a chaplain on those units. And then we found that what's interesting is that the training programs are actually reaching out to us, the wellness champions for different departments, including yours, which you're definitely ahead of the game on a lot of this anyway. And what's been seemed to be most successful is carving out some time from didactics so that the residents or fellows can have a half-hour session and space them over a few weeks. It's working out quite well. I actually spoke with Dr. Lightman about this yesterday, because trying to add anything on to people's very busy work schedules is really not a good idea. It doesn't work. Rather, replacing something for a limited amount of time with these sessions seems to have the most likelihood of success. We were lucky enough to get a grant from the Robin Hood Foundation. They're not-for-profit that does exactly what it sounds like, Robin Hood. They actually funded the first round of funding in 2002 for the World Trade Center program. And we are launching actually tonight the program. It's built upon a program that the Center for Special Health has had since 2015. We now have 20 faith-based organizations, and we train actually congregants to run health education workshops. And David Lamb helped us, endocrinology, Mary McLaughlin with cardiovascular illness. Thousands of churchgoers have actually participated in the workshops. We're using that model to now launch resilience building workshops. We have 11 churches, 9 of which we already are working with for the past several years. And as you can see, it's similar names for the topics. One difference is that we are having a 6th workshop on addressing injustice, and ODI has been working with us on this very important aspect. And we'll see how it goes. It's a different population, but the faith-based organizations, as you well know, are very pro-social, and we're hoping that we can help them with their community. And this is who we are. Anybody have any questions, please feel free to contact me directly. I'm around, as you guys know. Well, thank you.
Great. Thanks, Deb. Thank you, Dr. Marin, very much. So we'll open it up for questions. You want to put some in the chat? I think there was one in there already, Deb.
I see. When asking a survey.
You want to read it out louder?
Sure. When asking a survey, people may give an answer that they think the questioner wants to hear. How do you assess for that problem? It's an excellent question. That is the issue with surveys. They do not, they are good for screening. They are not good for diagnosing. And you really need to have a real interview with a person. Certainly for certain questions, for example, alcohol or substance use, you all know you probably have to double the amount that people say that they use, as to how much they use. So that the best way to solve that problem is to have a follow-up if possible. Surveys are great, but limited. That's one reason why we're so much focused on treatment actually and rounding. Next is difference in healthy older persons, DX and RX. Yes, older folks actually are doing better during the pandemic. Folks who are 65 and older seem to be less stressed, less likely to have behavioral health consequences. And there are many reasons why that could be. One theory is that, to get older, you have to go through a lot of vicissitudes and you build up your own level of resilience. Another is that these folks were not exposed to some of the issues that younger folks were exposed to. In terms of treatment, that's a good question. So for major depression, we just talked that for a moment, sertraline is the go-to medication actually for older adults, mainly because it's been studied the most. But if you speak with a geriatrician, as I often do, a psychiatrist, we tend to go for shorter acting medications. Older folks who have more medical comorbidities, unfortunately, are less likely to do well with treatments for behavioral health disorders. One thing that we do know for older adults is that social support is critical. And if one can have the patient engage with whatever support they have, that helps. The isolation of the pandemic, I even discussed that, as you well know, isolation and quarantine lead to behavioral health consequences, including depression, anxiety, substance use, dementia, and you probably all know also cardiovascular problems as well, and endocrinological problems. I hope it's a long-winded answer. I hope that gets to the point for that though. So the next question is, my well-being mentor taught me you can meditate away bad systems organizations rather than relying on individual ability to bounce back. Could we be looking at system level issues and organizations and how they could be leveraged to build resilience in relevant employees? That is so spot on. That's excellent. The studies that have looked at community resilience in the presence of a disaster, like Hurricane Sandy, for example, was found, what a surprise, poor communities didn't do as well. And you can't expect a person to just stand up with their bootstraps when they're experiencing poverty, violence, racism. And that is a challenge that, in fact, we're embarking on this workshop series with the churches tonight. That's my trepidation. I think what we need to do, and we're trying to do with the employees here, is that's where we're going out to SP2 levels. We're going to the docks, we're going with She Time, the cart we have, because they have to feel that something is there for them. I think the reason we have almost 20% of 1199 is that they go, wow, I can actually get some care here. But it's a very difficult, and I think we have to be very careful. I think that we, on this phone call, we have a lot going, right? A lot of folks don't. So it's long-winded answer again to a very complicated issue. I think being anti-racist helps a lot, being very proactive, talking about that. I think it really, being humble, saying things, looking people in the eye in the elevator you normally don't look at, acknowledging them, let them know that they're seen. Little acts of kindness.
Other questions for Dr. Marin?
I just want to get back to the one about the screening. One thing is that, doctors say, how are you doing? And the person goes, fine. We have to ask, how are you really doing? I do that with my colleagues here. It's not a bad way to try to get folks to open up a little bit. I know you have short visit times. I understand all the exigencies there, but I think just acknowledging, since you now know that 30% of folks who are post-COVID, who had the illness, have a behavioral health issue, I think being attuned to that. We have a very good post-COVID-19 program, as you well know, right downtown. It's wonderful. We'll work closely with them too to refer folks to us. I think just acknowledging is important.
Great. Well, Deb, thank you very much for spending the time. I think it was great to hear all the great work that you're doing and for everyone to see what opportunities there are to, talk to someone and get some help if needed. So thank you very much. I appreciate it.
My pleasure. Always a pleasure to work with you guys.
Great. Have a nice day, everybody. Enjoy. Thank
Thank you.
you. Bye, everyone.